Okay. So sorry. So taking up where we left off. So what we're trying to do is flatten the curve. So you can see on this graph over here that if you, and in fact this is true of all epidemics, you have a population that's immune naive. You have the spread of an infection, and you have this sort of rapid increase you've got this increase in the number of infections. Then people develop, you get herd immunity. All the people who've been infected are going to be infected. People have recovered, and you get sort of a decrease in the number of cases. This line over here is the capacity of our healthcare systems, and that line is going to be different in different places. And anything that falls above this line and under this curve is going to fall outside the capacity of your healthcare systems. So what we're trying to do with things like hand hygiene and cough etiquette and closing schools and sending varsity kids home is to just spread the number of infections. You're not going to end up with less people infected, most likely. The same number of people will be infected. You can end up spreading it over a period of time, which means that your healthcare systems can cope with it. And that's what we're trying to do here. And I think people are misunderstanding that. We're probably going to see widespread community transmission, whether we close our schools or our universities, and also it would be naive to think, in my opinion, that we can do it for 2 weeks and make a difference. So I think the country will have some important decisions to make within the next couple of weeks as we approach the date that the schools and the universities have been told they can come back. But the ways we can flatten the curve is hand hygiene. As I explained to you, it's contact spread. Cough etiquette, which is something that the general public has been taught. In healthcare facilities, contact spread, droplet spread, so we need to bear in mind what it is that we are trying to do, and we need to be scientific and sensible about it. And then airborne precautions will be necessary with some procedures, and I think this particularly is of importance to you as a group in terms of anesthetics. We very definitely want to keep as many mild cases out of hospital as possible. In fact, the UK has got all over their NHS websites, if you feel sick, please don't go to your GP, and please don't go to your hospital. And we also need to be spreading that news. If you've got a mild illness, stay away from the hospitals. Both SARS-1 and MERS were dramatically amplified in hospitals. They caused almost more than half of their infections were nosocomial-related outbreaks. So I think we need to learn from that too. So we'd be trying to keep mild cases out of hospital, and then we practice what we're now calling social distancing. And this is the idea of staying away from people, at least 1.5 meters, 2 meters, and the idea of cancelling large gatherings. Trying to stay away from shopping malls, places where large-scale infection can be amplified. And again, this is that we don't overwhelm the capacity of our healthcare systems. So I think most importantly for you is the use of PPE, and I think the message that we need to give to everybody is that PPE is a scarce source and it needs to be protected. We also need to use it to protect ourselves, particularly as healthcare workers. Incorrect uses of PPE to a large extent includes any community member walking around in it. My sister was at the airport about 2 weeks ago, and she saw 2 people walking around in gloves. They were just doing everything that they would normally do. They were picking up their suitcase, and they were talking on their cell phones, and they were touching their faces. The only thing they weren't doing was washing their hands because they were wearing gloves. So I think this sort of practice needs to be discouraged in the community. Even community members wearing masks. The only place for a community member to be walking around in a mask is if they're unwell, because what that does is quite effectively prevent droplet spread from symptomatic people. It's actually been looked at. Again, it's hard to measure at sort of on a pragmatic level, but it seems that community members walking around with masks can actually increase their risk of infection as they touch their faces more, and an incorrectly worn mask excuse me, an incorrectly worn mask is obviously useless. So we've mentioned that we need to protect our PPE. In fact, at the beginning, when we first started hearing reports of coronavirus, we sat down with our hospital management and with our district PTCs and tried to look at ways of acquiring enough personal protective clothing. We've got about 8,000 N95 masks as Universitas, and that sounds like a lot. But these things are actually supposed to be single use. So every time you use one, that's one less for somebody who's going to need it. I received a call the other day from from a casualty officer, and I said, well, before we go any further, is the patient isolated, and are you and the staff safe? She said, yes, no problem. In fact, it was 2 patients. I've given them both N95 masks. So patients do not need N95 masks. This is a totally inappropriate and a wasteful use of it. Patients need a surgical mask, and again, as we've said, all that is supposed to do is prevent the spread of large droplets. N95 masks, now, in all of the major guidelines, including your SASA guidelines, are reserved for the use of aerosol generating procedures alone. So I went to go and have a look at what are aerosol generating procedures. Intubation certainly is one of them. So is extubation, and we need to remember this in our ICUs. Tracheostomy, bronchoscopies. So I think we need to be very careful about the procedures that we're doing in our patients from now on, and we need to make sure that we preserve N95 masks for the people who are going to be intubating patients. So this picture here shows who it is that's supposed to be having what. So people in triage points or points of entry, and I'll show you now what we've done in our hospital to ready ourselves for this, should just be wearing a medical mask. That's all they need to do. As they sit there and ask the questions of, have you traveled, are you coughing, and separating patients, they just need a face mask. People who are collecting respiratory specimens, so the guy doing the swabbing, needs to wear goggles, a face mask, a gown and gloves. And this has changed. At the beginning of this outbreak, we were saying the guy doing the swabbing needs to be wearing an N95 mask. And I think the world has realized that these are going to be in global shortage. This person also needs to wear a gown, and I think that's obvious. If you induce somebody to sort of cough around as you're putting the swab in, you don't want the droplets to go onto your clothing, and the gown can be removed afterwards, and then obviously gloves. People who are caring for patients with coronavirus disease. So when our isolation ward at Pelenomi is full of patients with coronavirus disease, we will not be going in and out of there with N95 masks. We'll be going in and out of there with normal face masks if we're just caring for these patients. And the goggles, obviously, to protect spread to mucous membranes, and then again the gowns that we can remove afterwards. And these are actually basic precautions that are supposed to be taken in all of our patients that have got illnesses that are spread by contact or droplet spread. And I think if this outbreak does nothing else, it should really wake us up to what it is that we're doing. There's people who've got no idea how to put an N95 mask on, or how to fit test it, or how to use it. And I just want to ask myself, in a country where we have got TB as an endemic problem, where we have a high rate of drug-resistant TB, how is it that we cannot know how to put on the N95 mask? Your risk from XDR TB up until now has actually been, quite significant. So I think that a lot of good things, or we hope that a lot of good things will come out of this. So in terms of who to test, and this is maybe not so important for you, other than that you are ambassadors, being in an academic university and at least department, and also for members of the public. And we might all be called on to function outside of our disciplines if what's predicted and what's happening in other places affects us in the same way. So we are extremely stringent in our testing criteria, and that's because there's a worldwide shortage of testing reagents, and not only that, our lab capacity simply cannot cope with it. Not only in the government setting, but in the private setting too. The private labs are receiving currently twice their daily capacity every day. So the backlog just gets worse. And then people who need to be identified won't be identified, and that's the major problem. So people should only be tested if they have symptoms of an acute respiratory tract infection, and that being cough, sore throat, fever, shortness of breath, and if they have meet one of the epidemiological criteria. And that is close contact with a confirmed or a probable case, travel to areas with presumed ongoing community transmission, and work in or attended a healthcare facility where patients with COVID-19 were being treated en masse. We've added another one to that, in fact, and that's not so important for the screening, but more important for our ICUs, I guess, is that anybody who presents with a severe pneumonia with an unknown etiological cause or an unknown diagnosis. And we had a case like this in Universitas yesterday, a case of a child in 10B who was moved to the ICU, severe ARDS. They'd done all the other, the child hadn't responded to broad-spectrum antibiotics, and they'd excluded other bacterial causes. So I think the important thing to say here is we need to keep a broad differential diagnosis. In the studies where it's been looked at, even where these screening criteria are followed, out of sort of 210 symptomatic patients with presumed coronavirus disease, only 30 tested positive for other respiratory pathogens, and only 11 tested positive for SARS-CoV. So even with the screening criteria, I mean, it's an insensitive method. I think that the screening criteria will change shortly. I think as an epidemic progresses in the population, the travel history becomes less important. We've got ongoing community spread, so do we need to, I mean, people are going to become at greater risk of acquiring it just by staying at home. And then the other thing that will probably change at some stage is we'll have to say, well, we're not going to test, we're just going to treat, patients as they present. So how to treat this disease, and I think, again, as we've said, it's important to note that the majority of infections are mild, and if the patient can be adequately isolated at home, and this is something that they've got correct in many places around the world, and is something that I guess we're hoping to do here, if you can isolate patients in the outpatient setting, they should be managed at home. The aim here is solely to prevent transmission. I will mention a website at the end, but there's very nice guidelines for patients. And what I've done is I've now got it on my telephone. Most people in this place have got a smartphone or access to someone with a smartphone, and you can just WhatsApp the guidelines to our patients. So guidelines as to what you should do if you're at home, how you should use a mask, how you should engage with your family members, what you should and shouldn't do. The mainstay of therapy here is just supportive. We'll talk about it again. Probably paracetamol is the best thing for fever and pain. And then the important thing is to warn patients to return should they deteriorate. As we said, about 14% of cases should present with a severe disease and would be needed to be managed in hospital. Here, again, emphasis on looking at RPC precautions, monitoring for respiratory failure and sepsis, and then oxygenation support. And I think this is important, again, maybe for you, is that under the aerosol generating procedures falls non-invasive ventilation. High flow oxygen, nasal, and CPAP. And I think that we need to bear this in mind because this is probably an intervention that many of our patients would benefit from. One has to consider treatment for seasonal influenza because certainly initially we don't know what the diagnosis is, and we're coming into our winter and flu season, and we should see this more commonly. And then a conservative approach to fluid management has been suggested. So, and I think that there are very nice, in fact, there are nice ICU protocols. I'll show you one now. Then, sort of, as we said, in 5% on a global scale, certainly is what we've been seeing, patients that would need critical care for support for mechanical ventilation. I think the only important thing that I want to comment on here is that there's a limited role for glucocorticosteroids, and I think this is now quite clear in all of the guidelines. So this is a very nice guideline from the World Health Organization, and I see that we now have similar things. You know, there's so many guidelines coming out regarding all of this. We've got similar local guidelines that have been published for the management of severe acute respiratory infection when this disease is suspected. So I'd like to just spend a short while talking about the recent controversies, and I've been asked many questions about this. Firstly is the use of ACE inhibitors. I think these initially, early on in the epidemic, actually received quite a bit of attention as a potential therapeutic modality. And the reason for this is that, as you'll see here, is that the binding receptor for SARS-CoV is the ACE2 receptor. So there was an idea that if you blocked, this with ACE inhibitors, that you might prevent the transmission, and you might even prevent sort of spread within an individual. And as I say, this was looked at as a treatment modality, but there were then a couple of case series that showed worse outcomes in patients. I think the important things to note here is this was all patients with heart disease, diabetes, and they were on an ACE inhibitor. So there was this question drawn whether there was an association between ACE inhibitors and a worse outcome. And the theory here was that if you've got if you're on ACE inhibitors, do you not have the upregulation of ACE2 receptors? And the same thing here for non-steroidals. That's also the question, is if you get upregulation of ACE2 receptors, is this going to worsen the outcome? Both the ESC and the AHA have taken a very firm stance on this, certainly on the ACE inhibitor thing, and said that there certainly isn't enough evidence to suggest causality here. And I think that's what we need to realize, is that there's so much coming out at the moment. There's many observational studies. We need to be very, very careful the way we interpret evidence. and almost until you get a randomized control trial. And I'll show you a beautiful example of this now. It's very hard to make assumptions about what's going on. So the non-steroidal anti-inflammatory thing as well, and all of this stemmed from the French Ministry of Health saying, patients are doing badly on anti-inflammatories, don't take them. And I think that, then we had a couple of medical experts expressing their opinion, and all of a sudden the world said, don't use anti-inflammatories. We might still get clear guidance on that, and it might be confirmed that anti-inflammatories worsen the presentation. But I mean, there's so many confounders with this, and plus it just was one guy's anecdotal opinion. And I think, again, we just need to be so careful of the type of evidence that we back our practices on. I'd like to talk about some of the investigational agents, and certain investigational agents have been described. And again, up until now, it's been observational series where they've been using these things with anecdotal use. Oh, my patient got better when I gave him Lopinavir ritonavir. And I'd like to show you how wrong we can go with this. So at the moment, there's no evidence to recommend the use of specific antiviral therapies. I see that we yesterday had a new guideline released for South Africa after the NICD sort of put together an interim guideline early on where they took a firm stand, no treatment is supportive. They didn't recommend the use of any specific antiretroviral agents, antiviral agents, and the recommendations from all of the major guidance groups has been to use these only under ethically approved randomized controlled trials. So what we have done here is we have put up our hand early to be involved in one of these trials, and I think people around the world are being encouraged to do so, not just to increase our knowledge base on this, but also that we've got stuff available for our patients that may potentially work. The things that have received quite a bit of attention is this remdesivir, being used again via compassionate use in some places. It is a novel nucleotide analog, and with specific, with in vitro specific antiviral activity. Chloroquine and hydroxychloroquine have been used in other viral illnesses. They're attractive options not only because they're immunomodulatory, as you well know. They're used in rheumatoid arthritis and SLE. And the idea here is that they'd have a benefit on an immune modulatory basis in the setting of ARDS, but they also seem to have in vitro antiviral effect. Chloroquine is what we have available here. Hydroxychloroquine is not available, and this of the two compounds, the hydroxychloroquine has been shown to be more effective, or presumed to be more effective in vitro. Lopinavir ritonavir or Lopinavir and Cavexistat received quite a bit of attention. This was being used quite broadly in other places. And this is now, for me, the first example of how important we need to get the robust evidence from all of these things. Is that a study was published in the New England Journal yesterday that results of a randomized controlled trial. They randomized 100 people to receive Lopinavir ritonavir. They randomized 99 to just get standard of care, and there's absolutely zero difference in the outcome. There was no difference in the mortality. There was no difference in the time to clinical improvement. There was no difference in serial viral measurements. So obviously small numbers, but I think what there was a difference in was the gastrointestinal side effects. So there were severe gastrointestinal side effects noted in many of these patients, in fact resulting in stopping of the treatment in up to 30% of patients. So I think that we need to make sure that we do our best as well as a community to get to try and gather robust data. Tocilizumab is an interleukin-6 inhibitor. It's also going to be used. In fact, the clinical trial that we're looking at for our hospitalized patients will possibly include the use of this drug, or it's been built into the protocol for as soon as it becomes widely available to use, or more available to use. So in terms of a vaccine, and I think this is another important question that everybody's asking, is when will we have a vaccine available? I think this is fascinating. As of the 13th of March, there were 41 candidate vaccines listed on the WHO's website. So, I wonder if this isn't actually sort of unprecedented, this massive attempt to find a vaccine. There are already phase 1 clinical trials in the US and in China. So I think the point is even if you find a safe, effective vaccine, It's months away. Certainly to get production up there to anywhere near what we would need globally, it's months away. So we probably shouldn't pin too much hope in quarantining everybody until we get a vaccine. I think that unfortunately isn't going to work. So importantly, what can we do in our hospitals and practices? And I think what I've said is you need to have a plan. I think we shouldn't be caught with our pants around our ankles. We need to have a plan, and any plan, and we spread that at a district level as well. And unfortunately, a lot of this evolves as you start seeing your first cases. And we've learned so much in the last couple of days as we've seen the first cases in Bloemfontein. We've learned where there's holes in our systems and where we need to jack ourselves up. So I think the important things is one has to think of ways to minimize patient-hospital contact. As we've said, well, patients should stay at home. We're looking at on a provincial level towards getting repeat prescriptions for longer than a month, so getting patients to take home 3 months of prescriptions. This has been heavily debated. It's been looked into. It's a major issue because obviously our drug supply is always an issue. It's exacerbated now with most of the APIs coming out of China. So we will look at ways of doing this in situations where it's possible. So you don't have 120 people sitting in Kwakwa, a clinic there, waiting for their antihypertensives. We can't afford to be doing this. We have limited our outpatient departments. I hear that that's taken place at Pelonomi again today. One needs to carefully look at elective surgery, and I was of the opinion here that timing is quite important. There's many factors that need to be looked at when considering this, but I think the point is you don't want to end up with ICUs full of patients that are post-Whipples when this happens. We need to have readily available advice for patients that are going to be treated at home. As I said, I've put the resources all on my cell phone that I can actually WhatsApp to the patients. Guidelines for self-quarantines, that sort of thing included. As I've said, we're discussing the enrollment in quite a large, well-funded clinical trial. So we'll hopefully have drugs available for our patients with, severe enough to be hospitalized. We need to look at public and private collaborative efforts. I think that at the moment we're very fortunate. We are now one of the few sites that are able to do on-site testing. Even our private laboratories are sending tests to Joburg, and our capacity will. At the moment, we can test 22 at a time, and we can probably run twice a day. So our capacity is 40 a day. This will dramatically increase in the next couple of weeks as they get new machinery. So we will. We actually have we're well placed to be able to do testing. What I want to look at, our major problem is everybody's too scared to stick a swab in somebody's mouth. So what I would look at is, I've already approached Ampath with their little almost drive-through set up on the corner here, that they could maybe help us with swabbing if the need gets huge, and that we could then maybe help them with on-site testing. So we're going to have to look at ways that we can collaborate. We need public buy-in on our district outbreak response. So, for example, the delay between the private labs results and us getting notified, the private guys knowing who they should be speaking to when they've got positive cases, because obviously we're sending still tracer teams to go and investigate all of these. So we really do need to clear up our collaborative efforts, and I think this is so nice to initiate this today. So I think that the other thing that we'll need to say as well is if we do close whole clinics and elective surgeries, there's going to be a lot of people sitting around doing nothing. Bearing in mind that there's a casualty at Pelonomi that is overrun on the best of days, and they're now being asked to swab patients as people literally present en masse from the public. They're being swamped. The public is petrified. So now we're getting, I get phoned personally by members of the public saying that, their kid was sick and they went to Pelonomi 4 days ago. What should they now do? So I think that we are going to also need to look at interdisciplinary ways where we can help. If they close elective surgeries in the private hospitals, where the anaesthetists get involved in the ICUs and in forming intubation teams that the right people are intubating patients. And then the protection of PPE. You need to have a plan for how your PPE is protected. It needs to be under lock and key in a place where you as anaesthetists know how to get it. So packs in places where you'll be called on to intubate patients. In fact, what I've suggested already that this be kept in theatre, that you can grab it and run to the ward if you need to. But this needs to be protected for you as the people that really do need it. I want to leave you with this, and I think that it's important to note that sort of human suffering isn't measured by disease alone. You've all, I'm sure, in the last couple of weeks heard the saddest of stories. I heard a story the other day about a GP in a small town in the Western Cape who had the first case of coronavirus in the town. there's 4 GP practices there. Since he had that first case, he's not had a single other patient visit his GP practice because people are scared of getting it off the walls. So I think that it's, and there's so many stories like this, small businesses that can't afford to employ their staff any longer. So I don't know where this is. I don't know where this is going. I think there's so many unanswered questions globally. We have locally so many unanswered questions. For example, can we trust the fact that it's not going to harm our children? We actually don't really know. We know from the rest of the world that it doesn't seem to be a common occurrence that children develop severe illness. We don't know about malnourished children. We don't know about HIV positive children. And again, what will happen if we, for example, in China, they've quarantined everybody now for 3 months. What happens when they lift that and let everybody back into the sort of to normal life? One would expect really a resurgence of this because we've seen it's extremely hard to sort of eradicate. So I think that this is probably something that's going to be here to stay. We don't know enough about the immunity to know whether we're going to need to whether we would be potentially at risk every year. In terms of the virus itself, it doesn't seem to mutate at any significant degree itself. So we haven't seen the evolution of the virus, so it would be unlikely that we'd need a different vaccine every year, like influenza. So I think that's a positive. But whether we'd need to make ready to vaccinate people on a yearly basis from now on is also a question. So yeah, this slide I think just shows that there's been a massive effect on the world by this virus, and it's unlikely to turn around anytime soon. I'm going to say that are we going to say no questions, Eddie, or do you want to take questions from people here?
Let's take questions because I think everybody probably in the room's got one question.
Great, that's fine.
So let's start with Gillian. I think, and we'll give everybody that's got a burning question.
Sure.
Just 2 minutes, keep it short.
Sure.
So you don't have any evidence on the effect on HIV positive children. Do you have any statistics on adults?
No.
HIV
Very few. And all the observational data that's come out of other populations, the incidence of HIV is been low. So we've got no idea. We don't know what the effect of, one would think that you try and extrapolate from other illnesses. So influenza, we know that particularly patients with low CD4 counts, we accept are at greater risk. So I think that one should probably extrapolate from that, but there's definitely no data, and that's where I also think that we can play a role. We need to be collecting evidence on our patients because we are very definitely a unique population, and we've probably, unlike, well, I should be careful what I say, but most likely unlike the rest of Africa, we've got the ability to actually be doing this. So that's also why we are getting involved in this trial, because we just think at least we get our patient population represented. It will be a global thing, but at least we'll have data that comes out of our population. Yeah.
As you answer your question, the guys that need to leave for theatre, please leave as you've got your...
Oh, Riette is here as well, Eddie, for the...
I know.
Oh, yeah.
You're
going to record it?
Okay.
Okay.
And then me and Michu will do something for
okay.
the rest of the community.
Okay.
Any question? Any question? Any question? At the back, any question? At the back, question. Marie, question. Nadia, question. Didi's got a question.
Yes.
So thank you very much for this detailed presentation. So it's the fact that it's affecting HPV detectors is not true, isn't it?
No. So it very definitely. You'll remember that slide that I showed you. This one over here. Sorry. It's entry into the human body is via the ACE receptor. That's its mechanism of entry. So the idea that ACE inhibitors are making it worse is not proven. It was probably, and I mean, I think what one needs to do is randomized controlled trials, and then we'll know. Unfortunately, we don't have that available. But I think we need to be very careful about making inferences. So where this thing came was from 3 observational studies that looked at, what medication were people on, what comorbidities did they have, and what were their outcomes like. And patients with diabetes and with heart disease did worse. And many of them were on ACE inhibitors. And I think that this is a confounder. The concern that an ACE inhibitor upregulates your receptors and might therefore affect spread and proliferation of the virus